Okay, so today I'm trying to read disorders of sodium in water balance. Let's go through it. So basically, we'll be discussing about osmolality. What does it mean? Some common disorders that we see in clinical practice, like diabetes insipidus, cerebral salt wasting, SIADH, syndrome of antidiuretic hormone secretion, an approach to polyuria and polydipsia. Just a few basics to start with. All of these things. Uh, First, we have to understand our total body water. The composition of the body water is basically there is total body water. We have usually most of the compartment is composed of water. So 50 to 70% of body weight is total body water. It is divided into two compartments: extracellular fluid and intracellular fluid, which is separated by a membrane. That membrane decides the relative concentration of solutes on each sides. So ECF, this extracellular fluid, is further divided into three: intravascular, interstitial, and transcellular fluids. So all these compartments have slightly different, but concentration of solutes, but predominantly difference between sodium and potassium is between ECF and ICF. The distribution of water in these compartments, that is important. That is governed by what? That is governed by some particles which are osmotically active particles. They decide the relative distribution of sodium and potassium in various compartments. We'll go through each and everything. That is the relative distribution. Extracellular, intracellular, we can see in neonates, newborns, their percentage of total body water is more. It's around 80%. As the child grows, it comes down slightly. From 1 month to 12 months, around 70%. 12-year onwards is around 60%. So relative distribution, you can see ECF is 45, 35%, 30%, 40%. In 12 years onwards, ECF becomes 20%, ICF contribution becomes more. ECF is subdivided into these compartments: interstitial, transcellular, and 5% weight by plasma. So what is the driving factor between water movement between these compartments? That is, you have to understand tonicity and osmolality, to compare two concepts. Tonicity is the measure of the osmotic pressure between the two solutions. So unlike osmolarity, tonicity is influenced by solutes which cannot cross this membrane. These are osmotically active solutes which do not pass between the membranes easily, like sodium, and they drive the movement of water. So if they are more on this one side, they will tend to drain water towards this side. They will attract the water towards that side. Osmolality is different. They are also solutes per unit mass of solvent, but they do not create a force of movement of solute of water around a membrane. So osmolarity is the same usually in the ICF and the ECF. Tonicity is the measure of the osmotic pressure gradient between the two solutions. So we can have isosmolar solutions which are not isotonic. So we'll further discuss these concepts. This is the typical distribution of electrolytes. Extracellular fluid has more sodium, low potassium. We know that we measure blood plasma. So you get a higher sodium. Sodium is around 135 to 145. Potassium is only 4 to 5, 3 to 5 milligram per liter. Intracellular fluid, on the other hand, has a high potassium, low sodium. This distribution of electrolytes is maintained by this sodium potassium ATPase pump. You see, when we take a sample and it's squeezed, you tend to get more of intracellular fluid comes out into the blood, and you get falsely high sodium levels. That happens because of this distribution. So what is serum osmolality? Serum osmolality is the number of osmoles, osmotically active particles in the serum. Normal range of serum osmolality is 275 to 295. 2 into sodium plus glucose by 18 plus BUN by 18, 2.8. This is, so by looking at this formula, we can clearly appreciate that the main constituent, main force behind serum osmolality is sodium. This is serum sodium. Then comes glucose, but it is divided by 18. So it also can generate osmotic tonicity. It can also drive uh, movement of fluids across membranes, but that for that it has to be very high, which happens in cases like diabetes mellitus, DKA. When you had very high glucose levels, then they also tend to get Patient gets dehydrated because of lot of fluid dehydration, fluid coming out. BUN, if it becomes very high in case of renal injury, renal kidney patients, end-stage renal disease. If it becomes very high, then that will also become a source of uh, contribute to significantly increase serum osmolality. When we measure it, basically it's number of solutes per kilogram of water. High osmolality means more solute, less water per unit volume, and vice versa. Effective osmoles. This is important. So sodium, glucose, and urea we have seen, they all can exert osmotic force across cell membrane, but sodium is the main contributory factor. So there are two formula. First formula is 2 plus sodium by glucose by 18 or BUN by 2.8 or urea by 6. Second formula is just when we are just looking at tonicity, we tend to ignore urea because urea usually in the normal ranges does not contribute that much to movement of fluids across the membranes. So this tonicity formula is basically 2 into sodium plus potassium plus glucose by 18. But anyway, sodium remains the main factor. Again, we can see the osmolality is the amount of solute dissolved in 1 kg of water. For example, when we look at the normal fluid that we see, that is sodium chloride, it has 154 milliequivalent sodium per liter, 154 chloride per liter. The total osmolarity becomes 154 plus 154. It's around 300 milliosmol. So it is, as you compare to plasma it has 275 to 285. When we compare to plasma, sodium chloride is slightly hyperosmolar. So this slide is extremely important. All the common fluids that we see in normal clinical practice that we use. Sodium normal saline osmolarity is 308. The just seen 154, 154. It's an acidic fluid. Half NS. Here you get 77 milliequivalent. Just divide by 2 is half. 154, 77, 77. So osmolality is also 154. So it's a hypotonic fluid. 3% sodium chloride. 513 milliequivalent per liter sodium, 513 milliequivalent per liter chloride. It's a hypertonic fluid. The name itself is hypertonic saline. It's also acidic. Look at the osmolarity is very high, 1026. The more osmolar the solution, the less amount of time you will be able to give it through a peripheral vein. So peripheral veins have a limited capacity to give a hypertonic solution. So you need a wide bore cannulas, preferably center lines, so you can to be able to give these concentrated solutions comfortably for a long time. Let's look at ringer lactate. This has 130 milliequivalent per liter sodium. Chloride is physiologically balanced here. It's 109. It is not 154, 154. So what happens with normal saline when we give it for a long time? It decreases the strong ion difference. Body normally plasma has a difference of 40 to 50 between sodium and chloride, which are the strong ions. If you give a lot of sodium chloride, you will cause hyperchloremia, decrease the strong ion difference, and because of this decreased strong ion difference, you will get acidosis. So this is a physiologically balanced fluid. This KB light that we plasma light here, it's even more balanced. So these are balanced because here some amount of chloride as the anions have been replaced by some other anions like lactate here and acetate and gluconate here. So you get the osmolarity is relatively isosmolar and it's more physiological in the sense of the distribution of the strong ions. D5 water, if you look at, there is no sodium at all here. Glucose is 50. So osmolarity is 253, but it doesn't exert any tonicity. If you give D5 water in the vein, it will not increase your intravascular volume. Everything will go out of the membrane immediately. Similarly, half DNS and half RL. Look at bicarbonate is also extremely hypertonic. It is even more 7.5% bicarbonate, even more hypertonic, hyperosmolar than 3% NS. It is 1786. It has 893 milliequivalent per liter of sodium. Similarly, albumin. Albumin we ignore, but albumin also has a lot of sodium and is hyperosmolar one. 330, 330. These colloids like Hita starch, they are also concentrated. They also have sodium chloride in equal quantity, but they are very relatively higher. So these blue is hypertonic. These green solutions are relatively isotonic. These are hypertonic. So water regulation depends actually dependent upon the total intake water. What is the losses in health? Usually intake is regulated by thirst and the availability of water. and only a modest increase in tonicity induces an intensive sensation of thirst from osmosis sensors in the hypothalamus. The thirst and water depletion. These are two important factors which increase your vasopressin secretion. Vasopressin then regulates how much urine we are going to pass and how much the thirst levels. So renal water excretion involves sufficient perfusion and sufficient amount of osmolytes because kidneys cannot excrete pure water. So if you want for kidneys to be able to excrete water, some amount of osmolytes has to have go through with the what maximally dilute urine with the kidney can excrete is around that's hypo how much diluted urine can be excreted is 50 to 100 milliosmol per kg. How the body is regulation is done. So whenever your hypervolemia, excessive fluid volume in the body, it is sensed by receptors. This hypervolemia excess fluid will inhibit antidiuretic hormone, which is the vasopressin. This release will be inhibited. So there will be a lot of increased urination of dilute urine. Also, aldosterone release will be inhibited. Sodium retention will be less. Thirst will also be inhibited. So all of this will lead to less water intake, more secretion of dilute urine. So normal fluid volume will be restored. Whenever we have hypovolemia, deficient fluid volume that we see commonly dehydrated patients, what two, three, four things will happen. It will stimulate thirst. So if you are a healthy patient will tend to take more water. Normal fluid volume will be restored. Antidiuretic hormone release will be stimulated. Vasopressin release will be stimulated, which will lead to decreased urination of a concentrated urine, and aldosterone release will be stimulated. Aldosterone is also going to lead to sodium retention. Here we all see the same things. Whenever we have to look at whenever you have nausea, hypoglycemia, pain, you see these are very common findings in critically ill patients, critically ill children. All of these conditions lead to increased secretion of vasopressin. Vasopressin secretion is going to decrease renal water reabsorption. So as per osmolality, osmosensors thirst will also be stimulated. So all of these things are going to regulate the decrease the urine output. This vasopressin is secreted from the posterior pituitary. Secretion of vasopressin occurs by the hypothalamus. The hypothalamus releases this signals, and from there this pituitary organ releases the vasopressin. Usually secretion of vasopressin by the hypothalamus occurs as little as 1% increase the plasma osmolality. So as long the osmolality increase is the earlier mechanism of increase in vasopressin as compared to thirst. Much larger increases osmolality is required to trigger thirst. So thirst is stimulated later, but vasopressin secretion happens even earlier. So what vasopressin does is water excretion in the normal kidney is regularly actually regulated by this hormone, arginine vasopressin. It reduces renal water excretion by increasing passive reabsorption by opening the aquaporin too. If there was no vasopressin secretion, the kidneys will always be excreting a totally maximally dilute urine that we have seen. So AVP increase can cause urine to be maximally concentrated up to 1200 milliosmol per kg. So it squeezes the kidney to release uh, less urine, a more concentrated urine. So control of water balance, again physiology, extracellular tonicity, osmolality has to be kept within normal range. Extracellular fluid tonicity depends on the water intake and excretion. Extracellular fluid volume also depends on sodium intake and excretion. But the overall control of tonicity and volume again depends a complex interplay. So here are hormonal, neural, paracrine systems. We have discussed this that thirst threshold is higher for vasopressin release as compared to osmolality. So whenever there is hyperosmolality, vasopressin is released first before thirst is initiated. Thirst stimulation happens later. Also, whenever water is taken, the chemoreceptors will rapidly downregulate vasopressin release following water ingestion. First, is whenever you have hypersmolality, first will be increase of vasopressin so that the amount of urine becomes less. And all of these things get impaired when you have impaired thrust. We will see the examples later. So all of these things regulate sodium concentration, sympathetic nervous system stimulation. Loss of sympathetic stimulation will cause vasoconstriction. Inhibition of ANP. Hypovolemia will cause activation of renin-angiotensin axis, more aldosterone levels, more sodium retention. Also, sympathetic stimulation will lead to increased antidiuretic hormone, which is vasopressin, more sodium retention, thirst. Low plasma osmolality also will lead to increased ADH. This will also all tend to regulate the sodium and water balance. These are the common abnormalities of water metabolism which lead to brain damage. Excessive hyponatremia, excessive hypernatremia. Both of these things can cause brain damage. Common disorders clinically seen are syndrome of inappropriate secretion of antidiuretic hormone SIADH. It can be postoperative, it can be water intoxication, it can be diuretics. Common hypernatremia scenarios are gastroenteritis, food restriction, diabetes insipidus is the primary cause if you have ruled out other causes, and sodium excess is a rare cause. So, two common opposite scenarios are SIADH and DI. In SIADH, patient is soaked inside and it's a dilutional hyponatremia. Sodium osmolality, sodium is low. It can be because of this low sodium. This can be seizures, raised ICP. In diabetes insipidus, what happens is a lot of free water excretion is happening through the urine. So you're getting a hyperosmolar condition with patient is dehydrated inside. So clinical parameters to distinguish among these three common problems that we see are that is SIADH, cerebral salt wasting, and central DI. So SIADH is a hyponatremic disorder. Salt wasting is also hyponatremic. These two are separate, and central DI is also hypernatremic condition. In SIADH, serum sodium is low. In cerebral salt wasting, also serum sodium is low. Urine output here will be normal or slightly lower. In cerebral salt wasting, it will be high. Lot of solutes are being excreted in the urine. That is the cause of increased urine output, and patient may be dehydrated. So these are the two main differences between SIADH and salt wasting is that urine output will be high, intravascular volume will be low, patient would be dehydrated. An SIADH patient is relatively either no euvolemic. It's said that they are euvolemic. Urine sodium is high SIADH, is inappropriately high. Despite the serum sodium being low, their urine is not retaining the sodium and it's inappropriately high. And of course, in salt wasting, the name itself is salt wasting. Lot of solutes and predominantly sodium is being lost in the urine inappropriately. Central DI is a condition of high urine output, high serum sodium. Here urine output is high, but here its urine is totally diluted. Only free water is being excreted. Low osmolar urine is being excreted. Urine sodium is going to be low because it's a diluted urine. Solutes are less. Intravascular volume status will be low here as well. So both salt wasting and central DI have a low. Dehydrated patients are dehydrated. Vasopressin levels are high, here low and low. So when we have hypovolemic hyponatremia, decreased effective blood volume, common mechanism is increased vasopressin secretion. Whenever we have SIADH, the name itself says that inappropriate ADH is being excreted, vasopressin is more. There is water retention, volume expansion, and hyponatremia. It's dilutional hyponatremia. In salt wasting, more of renal salt losses. The volume depletion is happening because of salt losses, most urine output. Here also, vasopressin will increase. Volume depletion with hyponatremia is going to happen. When we have polyuria, urine output more than 4 ml per kg per hour is typically said to be polyuria. You can have two conditions. Urine osmolality is more than 300 milliosmol per kg. This could be because of we have given very concentrated solutes like mannitol, high glucose or urea. It could be because of that. If the urine output is very high and urine osmolality is less than 300 milliosmol per kg or hypoosmolar urine, then we look at plasma osmolality. If urine is hypoosmolar, plasma osmolarity is also less than 300 milliosmol per kg. This means Then it's a hypotonic polyuria, where the patient is excreting excess water, or it could be post-obstructive diuresis. If osmolality is less than 300 and plasma osmolality is high, more than 300 milliosmol per kg, which means it could be diabetes insipidus, because plasma osmolality is going higher because we are losing free water. If the patient is in shock, we have to give a crystallite fluid bolus to first correct the shock, despite the sodium being high. First, we can have to give some type of isotonic fluid. Then we start with some medication like desmopressin to replace give some vasopressin-like action so that some amount of salt retention starts happening. If there is no response to desmopressin, that is nephrogenic TI. Hypernatremia correction, again, if there is a risk of intracranial hypertension, then you have to maintain a stable sodium and avoid very fast correction. If there is no intracranial hypertension or relatively acute hypernatremia, we can aim for a slightly quicker correction of around 0.5 millimole per liter per hour. Usually, sodium fluctuations should not be more than 10, 12 milliequivalent per liter in one day. Once again, I think this slide discussing the same thing, and overall, once again, we're looking at volume status in hypernatremic conditions. If you have hypovolemia, total body water is less, total body sodium is less, and urine sodium is more than 20. This is usually because of secretion of osmotic diuretics, give renal losses. If urine sodium is less than 20, sodium is less. It could be extrarenal losses like burn, diarrhea, fistulas. If urine sodium is variable, again DI hypodipsia. Very rarely you will get hypervolemia with high urine sodium. That is because of sodium gains and endocrine disorders like hyperaldosteronism, Cushing syndrome, massive amount of hypertonic sodium infusions. Those can be the causes. What happens in diabetes insipidus? You get polyuria, polydipsia, which is predominantly vasopressin deficiency. Central DI. If there is vasopressin insensitivity at the level of the kidney, that is nephrogenic DI. Typical diagnosis simple. Serum osmolality is going to be high, more than 300 millismol per kg. Urine osmolality is going to be low because we are secreting diluted urine. DI becomes very unlikely if the serum osmolality is less than 270 millismol per kg or urine osmolality is more than 600 millismol per kg. Features of DI are hypernatremia, serum osmolality more than 300, decreased urine sodium osmolality, decreased urine specific gravity because it's hyposmolar. And usually there is polyuria. If you observe a polyuria for more than 4 ml per kg per hour for more than 2 successive hours in a patient who is likely to have DI, and you have to be always be alert about that patient is having DI. You have to exclude, of course, osmotic diuresis like recent administration of mannitol, extreme hyperglycemia, radioactive contrast material, or dilution or mobilization of polyuria after the post surgery. You have given a lot of fluids, and the patient may be excreting those fluids. Central DI happens in the settings, it can happen in the settings of intracranial pathology like tumors, histiocytosis, granulomas, following neurosurgery involving around the suprasellar region. The pituitary stalk may have been disturbed or damaged. And it can also occur after brain death. That's a common situation when you get really sick patients. Later on, when they get brain dysfunction, they tend to get into a phase of central DI. So it also can be post-operative. This post-operative DI may have a triphasic pattern, which is transient, permanent, or triphasic. Triphasic pattern. Transient UDI usually has an abrupt onset on the first or post-operative day, resolves within several days, but the other triphasic pattern happens when there is early post-operative DI in the first day or two. There is injury related to the neuronal shock, when suddenly there is no ADH secretion happening. So all diluted urine is being passed. You get early post-operative DI. After that, there will be some recovery in which inappropriate amounts of ADH will be secreted. So a lot of leaks will happen from the degenerating neurons. So you might get hyponatremia, followed by a phase where there will be permanent DI, which becomes evident after a week or so. The principles of management in DI remains replacing the ADH because there is no ADH being secreted in central DI to prevent ongoing renal water loss and replace any water loss which is already occurred. So keep Observation, hourly pulse, blood pressure, respiration, temperature, neurological status, of course. Clinical assessment of hydration status is essential. Keep monitoring the urine output. Child is losing a lot of urine. You have to replace that urine with hypotonic fluids. Fluid intake and output has to be carefully measured. If patient is initially in shock, then for just initial intravascular volume restoration, we have to give some isotonic fluid like normal saline or ringer lactate, followed by a slow correction. So replacement again that happens with hypotonic fluid. So we can go with N by 2, N by 3, and not possible, then we can add free water by say nasogastric tube. If you can use some formula, that's fine. But if you're not using, just add some free water. And but the key remains that keep checking sodium every 4 to 6 hourly, because we have to avoid too fast correction because of cerebral osmolar shifts that can be dangerous. And sodium drop should not be by more than 12 and 24 hours. Desmopressin, vasopressin is an analog. Vasopressin analog is the treatment of choice for central DI. It has less vasoconstricting effect than the native hormone, with less risk of hypertension and more sustained antidiuretic effect than ADH. Initial dose is about 0.5 to 2 milligram, given IV with an ADH antidiuretic action around 12 hours. Oral desmopressin is also effective, but its bioavailability is less, requires higher doses than IV administration. Duration of action is shorter, 6 to 8 hours. Intranasal spray can be given, but that's a crude management. In whatever you are giving, we have to keep measuring sodium and urine output to avoid overcorrection and undercorrection. Now, looking at coming to hyponatremia, it may be true hyponatremia or hypotonic, low osmolality, because you see sodium is the determinant of osmolality. Sodium is low, then osmolality should be low if it's true hyponatremia. So if you have low serum osmolality, low sodium, that's a true hyponatremia. If you have normal serum osmolality of 280 to 295 and hyponatremia, this may be because of some measurement problems, like in case of hyperlipidemia, hyperproteinemia, where you tend to this diluted segment of uh, is measured in a way that you get a falsely low sodium levels. If there is high serum osmolality, more than 295, and hyponatremia, that can happen when you have, in the cases of hyperglycemia, very high glucose, mannitol secretion. These are all solute rich. So this suddenly will increase your osmolality, but because of the shifts, there will be hyponatremia. So true hyponatremia, volume status, look at volume status. If the patient is hypovolemic, what should happen is that if the kidneys are fine, if the patient is hypovolemic, then kidneys should try to retain sodium. So urine sodium should be less than 20 milligram per liter. So whenever you have third space losses, gastroenteritis, kidney will try to retain sodium. Urine sodium will be less. However, problems with the kidneys, urine sodium will be inappropriately high. So urine sodium will be more than 20 milligram per liter. Common condition that we have discussed is cerebral salt wasting. If we have given diuretics, mineralocorticoid deficiency, again, sodium will not be retained. Salt losing nephropathy, ketonuria, RTA, relative acidosis. The patient is euvolemic, then also inappropriate secretion of sodium happens. The condition we have seen is SIADH. Also, in cases of glucocorticoid deficiency, hypothyroidism, hereditary disorders, some drugs. And if patient is there is hyponatremia, volume status is euvolemic, and urine sodium is less than 20. Then polydipsia, hyperprotonemia, exercise induced a lot of intake of hypotonic fluids, that may be the cause. If these are rare conditions, if not rare, this can happen. So patient is hypervolemic, so and sodium is less than 20. Sodium is actually low. This can happen with a lot of conditions like nephrotic. Your effective circulatory volume actually less. So sodium will be actually less, like CHF, cirrhosis, nephrotic syndrome. Urine sodium will be inappropriately high in these conditions in case of renal failure. So differential diagnosis of hyponatremia, intravascular volume status, and urine sodium. If you have systemic dehydration, volume status will be low, urine sodium will be low. If you have decreased effective plasma volume, both of these will be low. Kidney is fine, so kidney will try to retain the sodium. Urine sodium should be low. Primary loss, salt loss, both of because of salt loss, vascular status will be low, urine sodium will be low. SIADH, intravascular volume status can be normal or high, or euvolemic or slight hypervolemic, but urine sodium is inappropriately high despite the dilutional status. In cerebral salt wasting vascular volume, patient is dehydrated, urine sodium is very high. Decreased free water clearance, normal or high, normal or high. Other causes, factitious and all, let's skip those. So these two conditions require some close differentiation. Both of these conditions, cerebral salt wasting, SIDH, primary problems of hyponatremia that we see in critical patients. Urine osmolality is more in both of these because urine sodium secretion is more. SIADH is more than 100, more than 100, maybe slightly more in CSW. Urine sodium concentration is high, more than 40, more than 40. Extracellular fluid volume is less, definitely less in salt wasting. SIDH is say euvolemic or hypervolemic may be there. Body fluid, body weight or cumulative fluid balance will be neutral to slightly positive in SIDH. It is definitely going to be negative in salt wasting. Urine volume is going to be high. It may be slightly less normal or slightly less in SIADH. Also, other conditions, sodium balance will be definitely negative. They'll be neutral or positive. CVP is going to be low. The dehydration is definite more compared to SIADH. SIADH again, some people say that more of these are very overlapping conditions, and you cannot really differentiate between the main differences between the volume status. So SIADH happens, common causes that we see in children also as the pneumonia, positive pressure ventilation. These are all common conditions in ICU. Pneumonia, positive pressure ventilation, trauma, tumors, and meningitis, GBS, some drugs, carbamazepine, cyclophosphamide, vincristine. Post-operative states because of lot of pain, increase pain and stress, nausea, vomiting. All of these are strong inducers of ADH secretion. You get hypotonic fluid load, and other stresses are also common. Drugs causing a lot of drugs, antidepressants, carbamazepine, cyclophosphamide, hydrochlorothiazide, NSAIDs. Vincristine is a common cause of SIADH. Patients who are undergoing chemotherapy and receiving vincristine regularly, they tend to get admitted with exacerbated or exaggerated. They tend to have lower sodium, and sometimes there's after vincristine, the sodium falls even further. So usually the cause is SIADH, and we have to manage accordingly. Diagnostic criteria for SIADH are hyponatremia, serum osmolality less than 280 milliosmol per kg, absence of dehydration or overt edema. Typically, you will not get significant neither excessive volume overloading or nor excessive dehydration. When you see salt wasting, patients are going to be dehydrated. There is going to be inappropriate antidiuresis. So, excretion of urine, which is more concentrated than is appropriate for the degree of hyponatremia, despite the serum osmolality being low, there will be inappropriate secretion of sodium, slightly higher sodium, which is more than 1 milligram per liter, so more than 20 milligram per liter, high urine sodium. Urine is never maximally dilute, and urine osmolality usually around more than 100 millismol per kg. And usually we have, after ruling out, we say it is SIDH when we have ruled out other causes like renal, adrenal, pituitary, and thyroid function. Management predominantly is fluid restriction. Don't give too much hypotonic fluids. In high-risk patients with serum sodium is 130 ml or less with preserved circulatory volume, we can consider restricting fluids to two-third maintenance volume, and always restrict the fluids to half to two-third maintenance. If severe hyponatremia is there, we might have to give 3% saline bolus to bring it up, and furosemide may be considered to suddenly cause a secretion of more of the free water that has been accumulated. Symptoms of hyponatremia can discuss separately. The mild to moderate hyponatremia, you get mild symptoms like encephalopathy, headache, lethargy, depressed mood, inattention, impaired memory. If severe hyponatremia, they can be very risky, like seizure, cerebral edema, coma, death. All those things can happen. So low sodium is always very risky and dangerous. It should be avoided at all costs in clinical settings. Management, discuss severe symptomatic 3% saline. Chronic SIDH, you can just go for oral fluid restriction. Young children, you may not be able to restrict the intake a lot. Then you can sometimes rarely use demeclocycline to allow sufficient fluid intake for normal growth. And Vaptans have come up like they are these are a recent class of vasopressin antagonists. These are vasopressin antagonists. So they cause free water excretion. They promote the excretion of free water and increase sodium. They increase your serum sodium by around 5 to 8 millimole in the first 24 hours when we have given. Conivaptan may be administered intravenously as a bolus of 20 milligram followed by a 24-hour infusion of 20 mg. And tolvaptan is an oral drug given at a dose of 15 milligram per day. Not too many reports or evidence of a use in children, but maybe tried in chronic SIADH type of patients. So hypotonic hyponatremia due to presumed SIADH, severe symptoms 3%, no to mild food restriction, moderate symptoms again can give three little bit of 3% to bring up the sodium slightly, followed by fluid restriction and diuresis. CSW is the last thing. CSW is when you are having a lot of renal loss of sodium, cerebral salt wasting, also renal salt wasting. People are calling it like renal salt wasting these days. So primary cause where why salt is being wasted, it becomes contentious. Salt wasting defined renal loss of sodium during acute intracranial disease like subarachnoid hemorrhage, infection, mass, post-neurological state. It appears to be as a result of hypersecretion of A-type natric diuretic peptide ANP, which causes a lot of salt excretion. So usually these patients are hypovolemic, as we have seen. They are always dehydrated and hyponatremic. Urinary sodium output is urine output is more, and it can usually happens after a few days after a CNS insult. So SIDH and salt wasting both are common causes of hyponatremia and brain-related patients. Differentiation of CSW from SIDH may be difficult as both conditions are associated with hyponatremia in the setting of CNS disease. Attention to volume status here becomes key. A decrease in the ECF volume and negative salt and water balance is the main feature of CSW, which differentiates from SIDH. Weight loss and clinical evidence of dehydration may be present. Negative water balance also favors CSW, and you get a low CVP. And SIDH usually it will be CVP, or although CVP is not the status of intravascular volume. You have to see the other parameters like weight, cumulative fluid intake output, and other parameters, intravascular IVC status. So CVP is going to be low because CSW patients are going to be dehydrated more. The various theories why it happens. Decrease ADH, decrease salt appetite, decrease thrust, decrease sympathetic outflow, more decrease renal angiotensin ultrasonography excess, no sodium absorption, sodium is being lost, potassium sparing is happening, increased natriuretic peptides also increase the sodium loss, increase GFR, sodium, decrease sodium reabsorption, decrease water reabsorption, all this leads to increased salt loss in the kidneys. Lab features, you get elevated hematocrit because of dehydration, elevated serum protein concentrations, hyponatremia, serum osmolality is going to be normal or low. SIDH is always low. Urine sodium concentration is increased, markedly elevated. Usually CSW urine sodium losses are more than compared to SIDH. In SIDH also they are inappropriately increased. They are more increased in CSW. Treatment main management is maintenance of positive sodium balance along with water replacement. Treatment options are asymptomatic management may be managed with normal saline. Again, a lot of it's severely low sodium. We might have to give 3% saline, and after that we can give a bit of fludrocortisone around 0.05 milligram per day and maybe increase to 100 mics per day or 0.1 mg per day, so that some amount of fluid sodium retention may happen at the level of the kidneys. There can be some side effects of fludrocortisone like auxiliary pulmonary edema, hypokalemia, hypertension, and resolution depends upon the cause, and over a period of time it may improve. That's all in this session. Thanks. I hope it was useful.